So thank you for inviting me to give you this talk. So my talk is focused on lung neuroendocrine tumours. I'm Professor Was Mansoor, working at the Christie Hospital in Manchester. So what are lung neuroendocrine tumours? So these tumours arise from the lung, and in particular they arise from neuroendocrine cells. And there are 4 types of neuroendocrine tumours, and I've listed them here. They're roughly divided up into 2 groups: the well-differentiated cancers and the poorly differentiated cancers. The well-differentiated cancers include the typical and the atypical neuroendocrine tumours, and the poorly differentiated cancers, they include the small cell lung cancers and the large cell neuroendocrine tumours. You'll notice that the tumours are graded. They go from grade 1 to grade 3. So a typical neuroendocrine tumour is a grade 1 cancer. And if you liken this to the ascent of man, a normal man will be civilized, will live in a civilized society. You could possibly take this person into your home and they won't necessarily destroy your home because they're civilized. And that's really how normal tissue works. So normal cells work like that. They work by rules and regulations, and they tend not to step over those rules and regulations. A typical neuroendocrine tumor, which is grade 1, behaves like the mankind creature behind Homo sapien. So you'll notice that this man is carrying a weapon, but is more or less upright and will probably be largely civilized. And therefore, if you left him in your home, he may not hoover your house, but certainly wouldn't muck up your house. Okay, so they're fairly well behaved, and so they behave very much like normal tissue. The atypical neuroendocrine tumors are a little less regulated than that, and so now the person behind the person carrying the weapon no longer looks like a human being. And if you left them in your house, the bets are on that they certainly wouldn't hoover your house, and they probably would scratch your wallpaper. But nevertheless, they will behave by the rules and regulations largely set by you. The poorly differentiated cancers, so the grade 3 cancers, are like the ape-like creature right at the back of the picture. And so they couldn't be trusted in your house. They wouldn't hoover. They would probably rip up your carpets and throw your television about. And so they don't behave as a cancer is meant to behave. And so if you go by these analogies, you can realize you realize why grading of cancers is so important. So grade 1 cancers behave and grade 3 cancers don't behave. And this will become important as we go on in this talk. So the aggressiveness of cancers increases as you go from normal tissue to grade 1 to grade 2 to grade 3. The scope of this talk is to talk about the well-differentiated cancers, the typical and the atypical cancers, and not the small cell and the large cell neuroendocrine cancers. And so if we concentrate on the typical and the atypical cancers, the average age of patients getting these cancers is within their 4th and 6th decades. Typical carcinoids, as I've explained, have a slightly better survival than the atypical carcinoids. The prevalence within women is higher than in men. And most commonly, these cancers are the most common neoplasm appearing in children and late adolescents. How do these cancers present? The lung neuroendocrine tumours tend to present in a very non-specific way. So they mimic other conditions. So they can mimic chest infections, breathing problems. They can present with blood in your sputum. And so often they don't have a signature way of presenting. If they are peripherally located, so they're located on the edges of your lung, they may even be asymptomatic and so therefore found by incidental CT scans and chest x-rays. Centrally located tumours, so tumours near the big breathing vessels, tend to be the typical carcinoids, and they tend to present with obstructive symptoms, which give us a clue as to something might be wrong in a person, and therefore these patients can be discovered faster than those that present with non-specific conditions. Part of the problem with presenting with non-specific conditions is that these patients may well present late. And because they present late, there can be a limit to the possibility of curative surgical resection, and that certainly does impact on the patient's survival. It's as well to remember that these patients also present with syndromes, and these syndromes can be signature syndromes of this condition. And although there are many syndromes, the one to focus on is the one that I've outlined in red, carcinoid syndrome. So all neuroendocrine tumours, whether they are of lung or pancreas or bowel, can present with this particular syndrome, and it's associated with flushing, diarrhea, and leaky heart valves, which can lead to wheezing. In lung neuroendocrine tumours, so the atypical and the typical carcinoids, they present, this particular syndrome only presents in 1 to 5% of cases, so it's not very common, but often is much more severe than if it presented in a pancreatic neuroendocrine tumour or a small bowel neuroendocrine tumour. The principles of therapeutic management of these conditions. So in essence, once you suspect a person has got this particular cancer because of the symptoms and the signs and the syndrome that they may present with, the first thing that you need to do is gain some tumor histopathology. So you need to get a biopsy, and that biopsy needs to be processed by the pathology department to tell you whether this is a typical carcinoid or an atypical carcinoid. Once that's done, you then put the patient through tumor staging, so to look to see if the person has metastatic disease or whether his cancer or her cancer is localized. If it is localized, they may be amenable to surgical resection, which is the only chance of cure for patients with this cancer. Or if the cancer is metastasized, then the patient would be amenable to systemic therapy, so chemotherapy. Unique to these conditions are that we can assess their functionality. So I've already explained in my previous slide that they can present with syndromes, and so functionality assesses whether those hormones that are creating the syndrome are active or not. So we do blood tests to assess for that, and we also know that these cancers present with receptors on their surface known as somatostatin receptors, SSTR receptors, and I've shown you a diagram here with the receptors in red, and we can use targets to target these receptors and put traces on the ends of those targets to tell us whether the cancer exists or not, and we can sometimes change those traces for treatments and therefore treat the patient using those receptors. So just to go into more detail about that pathway that I've just described briefly. So making the diagnosis. So there's the key principles in making a diagnosis of either a typical or an atypical neuroendocrine tumor is to obtain a good biopsy. And that's done by invasive technique, and various techniques are either more invasive or less invasive depending on where the cancer is. Once you've got a good biopsy, you then pass that over to the pathologist, and the pathologist then looks at that sample and looks at the cancer, and firstly looks at the shape of the cancer cells. And so the pathologist will then get an inkling as to what type of cancer he or she is dealing with. And then they will stain that cancer using immunohistochemical stains, and I've listed some of them there, to tell us what type of cancer it is exactly. So neuroendocrine tumours of the lung, we know, stain with things like chromogranin A, synaptophysin, and CD56, and that then gives them a diagnosis. And this is what the pathologist will see under their slides, and to normal human beings that just looks like lots of purple dots, but they will be able to tell us and classify that neuroendocrine tumour according to a set classification as to whether this is a typical carcinoid or an atypical carcinoid. Once they've done that, then notable centres will ask for a little bit more information to give them a little bit more direction in how to clinically manage a patient. So they may ask the pathologist to tell them if there are cells within and around the cancers which show hyperplasia, so neuroendocrine cell hyperplasia, and whether there is a condition called dip-neck in and around the tumours, because that puts a slightly different complexion on things. The scope of this talk doesn't really cover dip-necks, but it is something that more and more clinicians are asking for to try and aid them in how to manage patients with this particular condition. The key message from this slide is that a good biopsy is the bedrock of good management. It's absolutely critical that the pathologist is confident with the diagnosis and is able to tell the oncologist or the treating physician exactly what type of tumor it is, whether it's a typical carcinoma or an atypical carcinoma or something else. The pathologists follow a set criteria, and we refer to this as the 2004 World Health Organization LungNet classification. This is due for modification shortly, but currently this is the template by which they work, and you can see that they have to tell you about the grade, the tumor differentiation, something called the mitotic count, and whether there is necrosis present or absent in the sample. We rely heavily on the specialist pathologists to tell us this so that we can then start to plan treatments for the patient. So once you've got the diagnosis, the next part of the patient's journey is to look at the stage of the cancer. So has the cancer spread? So it's localized, or has it not spread? Oh, sorry, apologies. Or has it spread, which means it's metastatic? If it's not spread, then curative therapies are possible. So surgery is the main port of call for that. If it has spread, then non-curative therapies are what is going to be offered, and these are often medical treatments. The medical treatments we do call chemotherapy. So accurate staging is extremely important, but to accurately stage a patient, you really need to know what the pattern of spread of these cancers are. And so the best place to look for that is when we resect patients, and then we look to see how those patients relapse in the future. And we know that typical neuroendocrine tumours have a 15% relapse rate, and atypical neuroendocrine tumours have a 50% relapse rate. And they tend to relapse to that pattern, so to the liver and lung commonly, lymph nodes commonly, bone, and then to other organs. And once you know that spread, then you know what is reasonable to use as a diagnostic radiological tool and what is not. So radiologically, you can use a chest x-ray, but if you look at that spread, if you use a chest x-ray, then all you notice is cancer in the lung. You won't notice the cancer in the liver or lymph nodes, etc., or possibly even in the bone. So although a chest x-ray is useful, it is limited in its usage. The gold standard radiology test is the contrast enhanced CT scan. This is the gold standard, and when a specialist requests this, it should always be of the thorax, abdomen and pelvis, because the spread is such. We can use MRI scans also, and these are used especially when there are indeterminate liver lesions, so spots in the liver which we can't tell whether that's due to spread of the cancer or something else. And so MRI scans can be used for that. We can also use MRI scans to delineate bone disease. And more commonly, we are using MRI scans in young patients where we want to avoid long-term CT radiation exposure, especially in follow-up. But of course, neuroendocrine tumours are unique because we can use radiology to stage, but we can also use nuclear medicine to stage these cancers. And many people have now heard about PET scans, and the most common PET scan that is used in medicine is what we call the FDG PET. So this looks at glucose metabolism of a cancer. And because grade 3 cancers, so the more active and the more aggressive cancers tend to utilize glucose more than the grade 1, grade 2 cancers. This tool is really more useful for the grade 3 cancers. However, there is some limited use for the grade 1 and grade 2 cancers also. The more commonly advertised PET scan that we can use for the grade 1 and grade 2 cancers are gallium DOTA PET CT scans. And so we know that 80% of bronchial or lung neuroendocrine tumours express these somatostatin receptors, and therefore we can use tracers to detect those receptors on the cancers. And we know that if we use gallium scans, we can pick up things that CT scans and X-rays can't see, and the literature would suggest that about 1/3 of our decisions are altered when we use gallium scans, where we realize that a person has more cancer than we initially suspected on a CT scan. So the key message here is keep in mind that these conditions are systemic in nature. They are not just lung neuroendocrine tumours, and they are cancers, and therefore they can spread like cancers. How do you manage these patients once you've got the diagnosis and once you've got the staging of this patient? So until recently, there was a huge unmet need with neuroendocrine tumours of the lung. There was no licensed or commissioned medication for these conditions until a drug called everolimus came along, which was trialed in large phase 3 studies, and that became the first licensed and approved drug by NICE. When we're considering treatments, however, the general strategy should always be first control the syndrome and then control the cancer. And so following on from those strategies, when we have a patient before us that has a cancer which is not surgically amenable, the first thing we're looking for is to see how we can maximally cytoreduce that person's cancer. So how can we kill as many cells as possible? Of course, that is just a surrogate for survival. And what we're really interested in is maintaining a person's survival and obviously that person's quality of life. And we can do that in a number of ways. Curative resection, if a person's disease is localized, but if it isn't localized, then there are many other things that we can do. And for the scope of this talk, I'm going to talk about the systemic management of neuroendocrine tumours rather than the surgical management of neuroendocrine tumours. So very briefly, the strategy once again, so an expert will have a pulmonary neuroendocrine tumour patient in front of them. The first thing they need to do is work out whether the patient has a functioning cancer. So does that person have a syndrome or a non-functioning cancer? If the person has a functioning cancer, and I've given you 2 examples here, then there is strong evidence about how to control and treat that syndrome. Then you have to turn your gaze towards how you can control the cancer to improve that person's survival. Then to do that, you split the treatment pathway into whether the patient has a typical carcinoid or an atypical carcinoid. Typical carcinoids, more commonly, we use observation because these are very slow growing cancers. And like I explained before, they behave like that civilized man. So they are reasonably well behaved, and so sometimes you can use observation only, but when the cancer starts to grow and misbehave, then you can bring in other agents to try and control the cancer. The evidence for controlling the functionality of a cancer is strong, and we know what to do here. But the evidence for a cancer that is non-functioning, where you are trying to cytoreduce the cancer, so improve the person's survival, etc., there is a lack of evidence for what we're doing. And I'm going to discuss this in the next few slides. The key message here is there are many options to control growth, but very little evidence. And as a consequence of that, when a clinician is trying to manage a patient, there is all sorts of confusion in that clinician's head. That you can see that there is no sequencing in this. Which order do you give a person treatment in? Well, it's random. It depends on where you land. It depends on which clinician is looking after you. And there is a price to pay for that. So if you have a rare cancer and you have not protocolized treatments, so you have poorly evidenced cancer treatments, then clinicians will give many treatments for the same condition. So you can see that here. So depending on which clinician you go to, they may give you treatment 1, another person may give you treatment 2, another person may give you treatment 3, and so on and so forth. The problem with doing that is you reduce the efficacy signal. So because everyone's giving different treatments, you don't know which treatment is the one that is working. And that confusion creates more anecdote, because the next generation of oncologists or specialists will do the same thing. They don't have a clue as to which treatment is the best treatment to give at a certain point for a patient. And what that does is diminish over time the academic interest in a particular speciality, because academic interests rely on attracting in grants, and grants rely on you putting down the evidence for giving a particular treatment. And that results in a reduced funding opportunity, and that results in poor research and development, and that completes the vicious cycle. So it's really important that clinicians and experts break this vicious cycle, and the way to do that is to bring in consistency in practice through strong protocols. If you can do that, if you can say to people, we're not going to give all these treatments for the same condition. What we're going to do is give a single treatment, and we're going to have an agreement between all of us that that's what we're going to give. And then we're going to measure the efficacy of that treatment. And if that treatment works, we will carry on. If it doesn't work, we will stop and give them the next treatment. Then what that does is it breaks this cycle. You get better signals, less confusion, and the academic interest returns, and you start to improve a particular condition's outcomes. And that's really where the focus of our energies have to lie. So evidence-based practice is extremely important, and that's a key message. It's important not only in this cancer, but in all cancers. So what is the evidence base? So the first treatment, the gold standard treatment when a patient comes to see a specialist, are the somatostatin analogues. And you may recognize the names, octreotide and lanreotide, so they've been around for a long time. They are the same class of drug, and we know that they control about 80% of untreated syndromes. So they're very effective. But we also have discovered that if you give these two agents, that they do have an effect on survival. So the yellow line represents people that had a somatostatin analog, and the blue line represents neuroendocrine tumors, patients that never had a somatostatin analog. And you can clearly see that the yellow line is higher than the blue line, implying in a survival curve that those patients are doing better. And so the median survival for a patient on a somatostatin analog is 39 months, compared to the median survival of a patient who has never seen a somatostatin analog, 18 months. And so, spurred on by this knowledge, 2 trials were set up, the PROMID trial and the Clarinet trial, to bring what we call grade 2 evidence to confirm the findings of this graph. And indeed, PROMID and Clarinet both came to the same conclusion, that in fact, putting people on somatostatin analogs doesn't just control the syndromes, it actually also controls the cancer very successfully. And you can see that here. The only problem for the lung neuroendocrine tumors was that either of these trials never included any lung neuroendocrine tumors in them. So the evidence for what to do with lung neuroendocrine tumors remained lacking. So we tried to gain that evidence using a trial called SPINETS, which would have sat alongside PROMID and Clarinet had we finished it, but we failed to finish this trial. It had to close in 2018 due to a failure to recruit patients. And the failure to recruit patients was because this is a rare cancer, and so not many patients are available to have the treatment, and so the trial had to close. What about chemotherapy? Well, the story isn't that different from the somatostatin analog. So once again, poorly tested in the past, attempts to move away from cytotoxic regimens is something that we are seeing in all cancers, including neuroendocrine tumors. But we know that chemotherapies tend to work well for the grade 3 cancers, so those poorly differentiated cancers, the misbehaving cancers, so the quick growing cancers. But we certainly need to explore chemotherapies alongside all these fantastic new biological therapies and small molecules that are appearing. The regimens that we've used are mostly old established treatments. There's nothing new in there. But the problem with all the trials, when you look at the neuroendocrine tumors, and especially the lung neuroendocrine tumors, is that the design of the trials has been fairly poor. We've used mixed histologies, especially in the 1990s and the early noughties. We used to often mix tumors, typical carcinoids and atypical carcinoids, with the large cells and the small cells. A lot of the trials are retrospective and therefore not designed. They were poorly powered, so the number of patients in a trial is very important in looking for differences between two treatment options, and often this was really poor because it's a rare cancer. Poor endpoints were often picked, so survival and quality of life were often ignored at the expense of response rate in these trials, and often the trials were non-randomized, and therefore what we call poor quality trials. As a consequence of that, we've never really known what the role of chemotherapy is with the lung neuroendocrine tumors. There's a similar story with the immunotherapy. So the immunotherapies have been around a long time in the management of neuroendocrine tumors of the lung and other places. But you can see once again, the story is very similar. The number of patients, so the powering of the trials has been very poor. Most of these trials have been retrospective. And as a consequence of that, the outcomes have been very different for the trials. And often very poor endpoints have been used, like radiological response rather than survival. There is a lesson to learn from the immunotherapies, and it's a lesson that, as experts in this condition, we mustn't make that mistake again. So with the knowledge that we have now of how the immune system works, if I ask myself retrospectively, would immune therapies have ever worked? Well, if I go through the immune arc very quickly with you, the key to the immune arc, and that's shown in this diagram, is that the immune system will not wake up to a cancer unless you spill what we call neoantigen. So the cancers, they have to break off little bits of the cancer for the immune system to pick up and recognize as cancer. If you don't get that, then the entire immune arc won't be set off. And so immune treatments simply won't work. So release of cancer antigen, as seen on this diagram, which is 0.1 on the diagram, has to happen. And the knowledge that we now have, we now realize that actually the neuroendocrine tumors of the lung may actually, in fact, not spill much neoantigen. You can see from the picture at the bottom that if you line up all the cancers and you look at the number of somatic mutations in a cancer, so the number of DNA mutations that the cancer undergoes, which is a necessary part of becoming a cancer, the more mutations you create, the more neoantigen you create. And in fact, carcinoids, you can see marked by the red ring, in fact, don't create many somatic mutations and therefore don't create many neoantigens. So in fact, you're probably getting, with low somatic mutations, low neoantigen production, and therefore failure to activate the entire immune system. And this is important because currently there has been a lot of interest in the immune agents, and it is important that the specialists in neuroendocrine tumours don't get carried away by all the interest in other cancers of the immune system if we can't work out how to cycle the immune reaction. However, we can learn from a good example. So I already said that everolimus has been approved by NICE, and it got approved by NICE because we use the correct way of introducing an agent into the pathway for these cancers. So we did a number of studies and we included lung neuroendocrine tumours in those studies, testing everolimus. The first one was Radiant 2. Then we tested everolimus with the lung tumours in Radiant 4, and that included about 30% of patients being lung neuroendocrine tumours. Then we were rewarded by the LUNA trial, which was included only neuroendocrine tumours of the lung. And by the end of that journey, from Radiant 2 to Radiant 4 to the LUNA trial, we knew that there is a signal and an efficacy associated with giving everolimus. And when we presented that to NICE, we were rewarded with commissioning of that drug. And so really, this is a way that we should be taking research forward. So the key message here is we have struggled to gain good evidence. We've borrowed from other neuroendocrine tumours to fulfill our practice. But Radiant 2 and LUNA really teaches a lesson about good research practice rewards us, and that's what we should aim for. And the immune story teaches us that if we understand a condition, then perhaps we will work out where we want to apply effort. So we are still searching for evidence and a position and a role for things like PRRT therapy, basic radiotherapy, immuno-oncology, and chemotherapy. And really, that will be achieved through formulating our research. But in order to try and standardize practice, we are working hard on protocolizing what we do so that the entire country and Europe work on the same thing. And so this is an example of a protocol which is currently working. So the general management pathway of non-resectable lung neuroendocrine tumours, you can see what you have to do. And so a physician can just log into this and work out what they need to do. And the advantage of that is that, of course, we can then look at what different centres have done, and we can try and find efficacy signals. So the key message here is if we follow a set pathway, we can collate evidence for efficacy through time. And that's another way of doing trials. And what's the reward for that? Well, in 2000, there were agents that were coming up, which other cancers have profited from. By 2011, 2018, many new agents have suddenly appeared, many new classes of agents have appeared, and so suddenly oncology is buoyant with options, and these agents go to cancers which are well studied, where the pathways are very clear, where the evidence of previous treatments are very clear. And if we want to be part of that, then really we have to make sure that we understand the carrot and the stick. So if we can demonstrate that we can do large studies, then we will be able to compete for these technologies with other cancers. So just to reiterate that, we have to learn to listen to the science. So this can be confusing, but we need more effort in basic science to translate to clinical science. We need to participate in the relevant science. So the immunotherapy example was an example of where if we understood the science, then we might have chosen in the 1980s not to participate in the interferon studies and instead expend our efforts on other treatments. So to do that, we need good exploratory and feasibility studies. And then, of course, we need to interrogate for signals of efficacy so that we know where to plough our money for well-designed studies. So are we standardized in the UK? So in 2018, myself included and a group of others listed here, we did something called the LEAP study, which was a study to really try and understand the incidence and the diagnostic and the management pathways for pulmonary neuroendocrine tumours in the UK in current practice. And we call that the LEAP study. And so we were particularly interested in the incidence, the prevalence, etc., of this rare tumour. We were interested in whether there was standardization in the management pathways and in the diagnostic pathways. To do this, we interviewed, it was a large undertaking, we interviewed 27 different specialists in 27 different centres across the UK, secondary centres and tertiary specialist neuroendocrine centres. All of the major geographic regions in England were used, and all the UK ENET centres of excellence were also represented. And so was there an evidence of a postcode lottery in the UK? Well, sadly, yes, there was. So there was a large variation in the follow-up of resected patients. So a high proportion of patients were being lost follow-up, which was of a particular concern. Most people agreed that the atypical neuroendocrine tumours, so the more aggressive of the two tumours, needed follow-up, but there was huge amounts of variation in the understanding of what it meant if a person was node positive, or if they had a typical carcinoid, or if they had an advancing stage of the cancer, about whether they should be followed up or not. Different centres were doing different things. There was a huge variation in the centres giving or not giving adjuvant treatments following resection. Similarly, there was a huge variation in diagnostic pathways. There was a variation in the availability of gallium DOTA scans, etc. And there was a variation in the pathology and the biochemistry being used across the country. There was a variation in treatment pathways. And of course, a variation in access to experts. And so the key message here was we currently do have a postcode lottery for this cancer. And there is a huge variation in practice, and therefore we need a strong protocol to work from as a nation. And what's the importance of all of that? So these are the last two slides, 2 or 3 slides in my talk. What's the importance of organising ourselves as a nation with this rare cancer? So this is just food for thought. Could NETs, neuroendocrine tumours, at some point be regarded as no longer being rare? And if they are no longer rare, do our standards of care change? So the big picture is when you pan back and look at where neuroendocrine tumours of the lung have been and where they are going. And so the picture on the left is of our planet Earth. And it was a picture taken by one of our satellites when it reached the end of our galaxy and turned around to face its origin. And you can see it's a tiny dot in the middle of space. It's being bathed by a single sunbeam, but you can see it's a very lonely planet, and that's sometimes how specialists looking after lung neuroendocrine tumours can feel. You have to remember that specialists are not hired specifically to look after lung neuroendocrine tumours. They are too rare an entity to justify the costs of an entire consultant. So most people will not be looking after this. So it's not a standalone disease group. Most people will have a major interest, and this is often a minor interest. It's not, this matter isn't helped because ENETs and UKNETs only adopted this particular cancer very recently, but now they have adopted it. I'm hoping that we will get much more help. They are, of course, a very rare tumour, and so therefore you've seen how difficult it is to recruit patients to trials with this particular cancer, and that doesn't help. But I think the thing that we need to pay particular interest to is that there are multiple specialists looking after a small number of patients, and that dilutes the specialist care. And really, we probably as a country need to work out which specialists really need to look after this particular cancer. Why is this important? Well, it is important because the graph on the left shows you the incidence of these cancers. And you can see when compared to the incidence of all malignant neoplasms, the prevalence of this particular cancer, so neuroendocrine tumours as a whole, not just lung, is equivalent to the incidence of more generalized cancers. And if you look on the graph on the right, you can see that the incidence of all these cancers has been increasing, but especially the lungs. So that's the top line in this graph. They have been rocketing, and that's probably because of better diagnostic techniques and better information to patients and pathologists to know what they're doing nowadays. But you can see that we are ebbing towards this cancer being less rare. And what's the consequence of that? Well, the FDA, the American agency, define rarity as a disorder or a condition that affects less than 200,000 persons in the United States. And currently, the projected prevalence in the US is 171,000, and remember, it's rising. So we're about to reach the tipping point in the United States of America where they will no longer regard neuroendocrine tumours as a rare entity. Similarly, in the EU, we regard a rare cancer as something which is less prevalent than 5 per 10,000 people. Currently, we are at 3.5 per 10,000 people, and we're increasing. So in fact, in the coming years, we may become a specialist interest that is no longer regarded as rare. And what does that mean? Well, if something is rare, you can justify a late or incorrect diagnosis. You can justify lack of access to appropriate therapies and clinical expertise. You can say that there are limited numbers of clinical studies because it's a rare cancer. You can say there's a lack of interest in developing new therapies because it's a rare cancer, because you can't get the signal. And you can say that you don't need the registries and the tissue banks to do the basic research. But in fact, once a cancer is no longer regarded as rare, you can no longer use these excuses. So from an expert level, you have to design MDTs that function, you have to improve the diagnostic pathways, you have to improve the treatment pathways and the follow-up pathways. They all have to be protocolized. As a researcher, you have to create registries and tissue banks, etc., etc. And you have to start doing quality trials. From the patient's point of view, which is very important, you can no longer sit in a room and say, look, we don't really know that much about a cancer. You have to start talking to patients and you have to start giving them information that they require to get on with their lives. And of course, as an educator, which is really important, you have to start educating the commissioners so that they can start funding you. And you have to start influencing the policymakers. And so it's really important that we get ourselves in order. And so if I conclude on all those key messages, if I collate them together, you can see that there is a single message that's coming through. So the first key message was a good biopsy is the bedrock of management. Second message was keep in mind the systemic nature of this when staging the cancer. Many options to control growth, but very little evidence. Evidence is key. We struggle to gain evidence. We've borrowed evidence from other places, but we have been rewarded by the Radiant and the Luna trials with everolimus. So therefore, good evidence gives you rewards. If we all follow a set pathway, we can then collate retrospective evidence, and even that is useful for a cancer that isn't very common. And the carrot and stick. If we can demonstrate that we can do large studies, so gain quality evidence, we can then start competing for new technologies. Sadly, currently, there still is a postcode lottery in the UK for resource expertise, and there is a variation in practice. And that's because currently there isn't the evidence base to fall back on. And so really everything falls on the experts coming together and gaining evidence for this particular cancer to move it on. And so that comes to the end of my talk. Thank you.